Welcome to lecture on initial strengthening approaches focusing on closed versus open chain exercises. I am Major Arun and today we will explore one of the most debated aspects of early ACL and knee rehabilitation, when and how to begin strengthening safely. We know that muscle atrophy and neuromuscular inhibition sets in within days after surgery, and if left unaddressed, they can significantly slow the recovery. Yet, aggressive strengthening to early risks damaging the graft or stressing fixation. Our goal in this session is to understand the biomechanics of different exercise approaches, apply safe progression timelines, and integrate them into a patient specific plan. By the end of this session, you will understand the fundamental biomechanical differences between closed and open chain exercises. We will analyze the strengths and weaknesses of each approach so you can decide which to use at different time frames. You will learn how to apply evidence based progression criteria rather than relying on generic timelines. And equally important, you will gain confidence in interpreting patient responses, recognizing when swelling, pain, or instability signals the need to modify or regress exercises. These objectives will equip you to integrate both approaches in a safe, structured, and personalized rehabilitation program. Our strengthening goals are both protective and restorative. First, we must prevent muscle atrophy and neuromuscular shutdown, especially in the quadriceps, which is notoriously inhibited after knee surgery. Secondly, we want to enhance early return to function by restoring strength that supports activities like walking, stair climbing, and transferring the weights. Third, the strengthening improves joint control and proprioception, which are key for balance and preventing secondary injuries. But we must always recognize the strengthening is often delayed in clinical practice because of graft protection concerns. Our role is to bridge the gap with safe, evidence based strategies. Close chain exercises like squats, leg press, and step ups involve the foot being fixed against the ground or surface. These recruit multiple joints and muscle groups at once, producing functional, coordinated movement patterns. Open chain exercises like straight leg raise, knee extensions, and hamstring curls involve the foot moving freely in a space. These allow isolated targeting of specific muscle groups, particularly the quadriceps and hamstrings. But they also generate very different forces on the knee joint. Understanding this simple distinction, fixed foot versus free foot, is fundamental to safe exercise selection in the early phase of rehabilitation. Mini squats with chair support are performed by holding a stable surface and flexing the knee to 30 to 45 degrees, keeping trunk upright. This closed chain drill activates quadriceps safely, promote joint compression, and improves co-contraction. Avoid deep flexion or dynamic valgus in the knee joint. In seated extension curl, the patient straightens the knee from 90 to 45 degree of flexion in a controlled manner. This isolates quadriceps activation while minimizing anterior tibial shear. Limit the terminal extension early and monitor for pain or patellar maltracking. The hamstring curl can be performed in either seated or trunk position. Starting from the knee extension, the patient actively bends the knee to a flexed position, typically up to 90 degrees, maintaining controlled movement throughout. This exercise specifically targets hamstring strength, which is critical for posterior tibial support and dynamic stability of the ACL. The clinician must ensure the patient avoids compensatory hip extension or pelvic tilt. Early emphasis is on controlled concentric and eccentric phases, progressing gradually with resistance band or weights as healing advances. Monitoring for pain, cramping, or asymmetry is essential for safe progression. Closed chain exercises encourage co-contraction of the quadriceps and hamstrings, producing compressive forces that helps to stabilize the knee joint. This reduces anterior shear stress and lowers strain on the ACL graft, making closed kinetic chain exercises safer in the early phase of rehabilitation. Open chain exercises, however, allows quadriceps contraction without tibial fixation, which increases anterior shear and places higher strain on the graft, especially in terminal extension ranges. This does not mean open chain exercise is bad. It simply means timing, range, and load must be carefully controlled. So, the practical takeaway is closed kinetic chain first for protection, then open kinetic chain introduced in controlled ranges when criteria are met. In the immediate 2 week phase, strengthening is about activation, not resistance. We use isometric quadricep sets, heel slides within a pain free arc, patellar mobilization, and gentle range of motion drills. These exercises re-establish neuromuscular control, reduces inhibition, and keep tissues moving without stressing the repair. At this stage, our focus is on quality, ensuring the patient can contract the quadriceps, achieve full extension, and maintain mobility without swelling or pain flares. It is a foundation building period, not yet a strengthening phase in the traditional sense. From weeks 2 to 4, we begin introducing closed chain strengthening in a very controlled ranges. Mini squats to about 30 degrees, sit to stand drills, and partial leg press are common options. These promote weight bearing, proprioception stimulation, and quadriceps activation in a joint safe manner. We carefully monitor for swelling and pain. If effusion rebounds or pain persists, load is too high and must be reduced. The principle here is gradual exposure to load while still prioritizing protection. Between weeks 4 to 6, open chain exercises can be cautiously introduced. Quadriceps strengthening is limited to 90 to 45 degrees arc, which minimizes strain on ACL graft. Hamstring curls are permitted through 0 to 90 degrees, provided hamstring was not harvested for graft. These exercises allow us to target isolated muscle groups that may not be fully activated by closed chain alone. But again, they must be monitored closely. Pain, swelling, or instability are signal to pass or regress. After 6 weeks, both closed and open kinetic chain programs can be progressed in a range, resistance, and complexity. At this point, graft incorporation is strong and the patient can tolerate more dynamic strengthening. Closed chain drills may progress to step ups, lunges, or deeper squats. Open chain can progress to heavier resistance or extended ranges, still respecting graft safety. The guiding principle remains the same. Progression is always criteria based, never just calendar based. Patellar mobilization involves gentle superior, inferior, and medial glide of the patella in supine position. This prevents adhesions, maintains mobility, and optimizes quadriceps activation. Always perform within pain-free range and avoid aggressive pressure. In heel slides, the patient bends the knee by sliding the heel along the floor or bed in sitting position or can be done in supine position with hip and trunk relaxed. This restores early flexion range and prevents stiffness. Movements should be slow and pain-free, avoiding compensatory hip lift. Passive range of motion exercise is achieved by physical therapist assisted or contralateral leg support to bend and extend the knee gently. The aim is to maintain joint mobility without stressing the graft. Avoid hyperextension or forced flexion in early stages. Shuffle press or isometric quadriceps set is performed by pressing the back of the knee into a rolled towel kept under the knee joint, holding the contraction for 5 to 10 seconds. This activates quadriceps without joint movement, maintaining muscle recruitment in very early rehabilitation phase. Ensure patient avoids gluteal compensation. Mini squats with support. Progress close chain strength performed with knee flexed to 30 to 45 degrees. Maintain upright posture and equal weight distribution. This builds quadriceps endurance while protecting the graft stress. Avoid deep deflection and asymmetry. In calf raises, the patient raises onto toes in a controlled manner, holding briefly before lowering. This strengthens gastrosoleus complex, aiding gait and push-off mechanics. Ensure symmetrical loading and avoid excessive sway. For isolated activation of gastrocnemius muscle, the calf raises should be done with knee extension. To focus on exclusively for soleus muscle, the knee should be kept at 15 to 20 degree of flexion and do calf raises. These both variations covers both gastrocnemius muscles and soleus muscle for specific muscle gain and strength achievement. In standing hamstring curl, the patient flexes the knee actively against gravity. This strengthens hamstring, restoring flexor extensor balance. Ensure trunk remains upright and avoid hip compensation. This progression adds thoracic resistance to seated extension, challenging quadriceps under load. Emphasize slow, controlled contraction with focus on symmetry. Avoid jerky movements that may stress the graft. In prone hamstring curl, the patient flexes the knee against TheraBand resistance while lying prone position. This strengthens hamstrings eccentrically and concentrically, improving posterior chain stability. Avoid lumbar extension or excessive hip lift during the exercise. Closed chain exercises reduce shear, promote proprioception, and integrate functional patterns that mirror daily tasks. They provide joint stability and encourage safe co-contraction, which is invaluable in the early phase. Open chain exercises, although less safe early, are critical later for regaining isolated quadriceps power, particularly for targeting vastus medialis obliquus. This balance of stability from closed chain and specificity from open chain creates the most comprehensive strength recovery. Ultimately, both are needed, but timing and dosing determine safety and effectiveness. Exercise prescription must also respect graft type. With bone patellar tendon bone graft, avoid open chain extension from 0 to 45 degrees early on to reduce anterior knee stress, while emphasizing closed chain squats in the same range. With hamstring graft, delay heavy hamstring work to avoid donor side strain and protect graft healing. With allografts, progressions are slower with lower loads because biological incorporation is delayed. This tailoring ensures that strengthening is not only effective but also safe for the specific surgery performed in a patient. Electromyographic research shows that closed chain exercises produces higher co-contraction of quadriceps and hamstring, improving dynamic joints protection. Open chain exercises, however, isolate quadriceps activity better and specifically enhance VMO activation, which is important for patellar alignment. The evidence suggests that both approaches are complementary. Closed chain for joint protection and function, open chain for targeted strength and balance. The art of rehabilitation is knowing when and how to combine them for maximum effect. Strengthening should be introduced based on clinical milestones, not arbitrary time points. We must consider tissue healing, graft incorporation, and patient specific signs such as pain, swelling, and range of motion. Gauge quality and functional ability are also critical decision points. For example, if a patient still has an extension lag, they are not ready for heavy strengthening. By applying an algorithm the, that integrates graft type, healing status, and functional milestones, we achieve safer and more individualized rehabilitation. During open chain strengthening, certain safety criteria must be met. Pain must be less than 3 out of 10 on numerical pain rating scale, and the patient should have full active extension with at least 100 degrees of knee flexion. Instrumented laxity, if tested, should be less than 1.5 millimeters at standard load. The patient should also be ambulating normally without crutches. If pain spikes by more than 2 points, range of motion decreases, or swelling increases, the exercise must be stopped and the program is regressed. Early strengthening after ACL reconstruction incorporates cross training exercises that target lower limb muscles while minimizing stress on the healing graft. Static cycling allows safe activation of quadriceps and hamstrings with controlled range and minimal joint load, promoting circulation and early endurance. Standing hip flexion, extension, and abduction exercises strengthen the hip musculature, enhancing dynamic knee stability and supporting proper gait mechanics. Proper posture is critical. Trunk upright, core engaged, and controlled movement without compensatory hip tilt. Additionally, the seated pillow squeeze targets the adductors and inner thigh muscles, improving medial knee support and enhancing overall limb control. Each exercise should be performed slowly and pain free, focusing on quality of contraction rather than repetitions, ensuring early neuromuscular activation while protecting the reconstructed ACL graft. Patient education is essential for safe strengthening outside the clinic. We provide home programs with clear demonstration of correct technique and posture. Patient should be taught to monitor their pain, swelling, and next day soreness, and to record these responses in a log. We also explain the difference between closed and open chain exercises so they understand why progression is gradual. This not only improves adherence but also reduces the risk of overloading at home. In conclusion, strengthening after ACL reconstruction begins with closed chain exercises to provide joint stability and proprioception. Progression must always be adapted to graft type, tissue healing, and clinical response, not simply time elapsed. Open chain exercises can safely introduce later within controlled ranges once the criteria are met. For long term outcomes, both closed and open chain approaches must be combined, creating a comprehensive program that restores strength, function, and confidence. This balance of science, timing, and clinical judgment is what defines effective rehabilitation. These recommendations are strongly supported by current evidence. Recent systematic reviews and cohort studies confirm the importance of both closed and open kinetic chain exercises in rehabilitation while emphasizing criteria based progression. Key references include meta analysis comprising of closed chain and open kinetic chain outcomes, and scoping review of safe open kinetic chain introduction. In clinical practice, evidence must be integrated with surgeon protocols and patient specific factors for best outcomes. For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm up and concluding with an appropriate cool down. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.